Good morning, it's Dr. Rutledge, and I'm here to talk to you about perforated ulcers today. And before I begin, I'd like to thank the group for inviting me to speak this morning. I'm also happy to announce that I'm allied with Dr. Ilan and our practice of bariatric surgery in Tijuana and San Diego. And so it's an exciting time to work with an excellent surgeon. Of course, I also need to always remember to thank my hosts for the last 2 years in the pandemic, Dr. Magenda and Dr. Kular, who put up with me while we were stuck in a lockdown. In fact, there are many people that helped me through the past 25 years, and there are too many to name. It's Dr. Dietl, Dr. Hargroder, Dr. Paragli, Dr. Mario Musella, Dr. Kular, and others. And after 25 years of traveling and teaching, now the ASMBS has endorsed the MGB. So, you know, what we say is better late than never, I guess, eh? This is an old map. After 25 years, the map looks pretty good. We've covered most of the United States and around the world. That map is kind of old, but it does show the MGB spreading in my case series. And this is my travels from Google Maps, and it doesn't show Australia on there, but we've been there as well. Okay, so today I'm going to talk about perforated marginal ulcers, and I'm going to be a little bit controversial. I know that'll be a big surprise to everyone. But basically, I'm going to comment that maybe sometimes the surgeon is the problem, and that a twisted, devascularized pouch, ischemia, and surgical technique might be important factors to pay attention to prevent marginal ulcers. So the take-home message and summary of the presentation comes up now in just 2 slides, and so you can leave and not listen to the rest of the presentation after this. Okay, so an ounce of prevention is worth a pound of cure. That's Benjamin Franklin. And so what do we know? A few things. Stomach acid is proportional to the parietal cell mass. That's just basic general surgery. And most studies, marginal ulcers, Roux-en-Y is greater than and more frequent than or roughly equal to MGB. But MGB, remember, has quite a large pouch in comparison to the Roux-en-Y. And remember, there were surgeons who said it was critically important to make a micro pouch. No young surgeons here might not remember that, but that means that the MGB has greater parietal cell mass and greater acid production. So if acid were a primary cause, we'd expect MGB, in contrast to having equal to or less than Roux-en-Y, we'd expect it to have a greater marginal ulcer rate, and that's not the case. And for those of you who are young, you might not remember the pouch is too big theory. There used to be these things, so you have to make the pouch smaller in the Roux-en-Y to treat the ulcer. And so I would say one conclusion I'd like to get across today is it's not just acid, it's ischemia and other risk factors, including the surgical technique. So we'll talk more about this, but that's one of the take-home messages I'd like to get across. It's focusing on prevention, because we don't have to have as many of these, I think, as we have. So think prevention first. If you rarely see it, I'd say that's a commentary on good surgical technique. And so my congratulations. If you're seeing it more often, maybe you'll want to get consultation from a friend or another surgeon who's seeing less and maybe has a different view of the anatomy and physiology of the operation. Particularly for MGB, there's a lot of experts now who have a long-term, over 10-year experience, over 500 to 1,000 cases, and they might be able to help instead of trying to learn how to manage perforated ulcers. Perforated marginal ulcers can occur. Fortunately, it's usually pretty easy. In most series, greater than 90%, it's a suture and a Graham patch. Rarely, in more severe cases where there's complete disruption or infection or tissue loss, then you divide the Gastro-Jejunostomy and allow the small bowel to go back to the small bowel position in the lower abdomen and do a gastrogastrostomy and get out quickly. In my opinion, there's never an approach or never a need or never an appropriate time for Roux-en-Y conversion or T-tube drainage, and we'll talk about that. And here's a little bit more detail before we go on with the rest of the presentation. So in case of MGB with perforated peptic ulcer, immediate resuscitation, CT, and exploration. If the exploration is negative, it should only take a few minutes, drains, and get out. If it's positive exploration, then it's either what we call a type 1 or type 2 type of perforation, and the type 2 is quite rare. Most commonly, it's a free lateral perforation at the Gastro-Jejunostomy at the most ischemic site on the anastomosis. It's usually there's an intact Gastro-Jejunostomy pouch and small bowel. And the treatment is a suture repair, the Gastro-Jejunostomy of the perforation, aspirate the abdomen and 2 JP drains and get out. Type 2 is more rare and more difficult to manage, but can be managed easily if you understand what to do. Usually there's massive damage and disruption of the Gastro-Jejunostomy, and there maybe have incipient sepsis in the patient. So as we say in trauma, move it or lose it. And the treatment should be 3 simple steps, in my opinion. Divide the Gastro-Jejunostomy, repair, if necessary, the small bowel or just close the defect, and then gastrogastrostomy using the remnant stomach as the site to repair, because it's one of the most well-vascularized organs in the abdomen and the body. Then drain and get out, plus or minus a feeding tube. In reference to T-tube drainage, vagotomy, or conversion to Roux-en-Y, in short, I say never. And we can talk about that. Okay, marginal ulcer has been known for a long time. Here's a paper back in 1921. And Roux-en-Y is known about it for a long time. One of the most problematic postoperative complications in this report. And there was a series recently of the New York State database of Roux-en-Ys, and they showed that after 8 years, almost 1 out of 10 patients, or more than 1 out of 10 patients, gets a marginal ulcer. In other words, get a Roux-en-Y, get a marginal ulcer. And again, this is not a similar number to what we see in MGB, and it's contrary to the idea that acid is the problem, because a Roux-en-Y with a smaller pouch creates less acid from a smaller mass of parietal cells. So here are risk factors, and what we'd like to point out today is maybe pay attention to not the usual suspects of diabetes, smoking, NSAIDs, etc., steroids, etc. It's ischemia, and that is potentially modifiable as modification of the surgical technique. So just remember, one of the most problematic postoperative complications, according to this study, is this marginal ulcers. But why? Why would this be? Because remember, Roux-en-Y is a subtotal gastrectomy. That's removal of 90% of the parietal cell mass. That's one of the best anti-ulcer operations we've ever had. We used to do this, I'm old, we used to do this before PPIs, before H2 blockers, back when wagon trains crossed go to the west. So, anyways, so why are we getting marginal ulcers in the Roux-en-Y? They have a very low acid output, and yet they are on PPIs. Okay, so again, I'm going to say this again, and I hope you guys can kind of pick up on this, but what do we know? Stomach acid is proportional to parietal cell mass, basic general surgery. Most marginal ulcers occur in Roux-en-Ys, and in the New York study, 1 out of every 10 or more, which is a lot more than most people are seeing in MGB. MGB is a large pouch, so has a larger parietal cell mass, therefore greater acid production. So if acid was one of the primary causes, then MGB should have a much greater marginal ulcer rate, and this is not the case. So recall the old pouch is too big theory, and I'll go through that if there are questions. But ergo, it's not just acid. And so my advice for you to take away from today's lecture is ischemia and other risk factors are important for us to pay attention to so we don't get perforated marginal ulcers. All right, but this is about how to manage them. This is from Dr. Shivaran's online video, and nicely done. Congratulations, and a pleasure to have been hosted by him and other wonderful surgeons throughout India. Free air, common presentation, purulence found in the abdomen, adhesions, dissected, and there's the wide open perforation. At the Gastro-Jejunostomy, and repair is straightforward. A suture with a Graham patch. Okay, now here's a Roux-en-Y with a perforated ulcer and in the usual position, and marginal ulcers are reported, I think, in most series, depending on who you are, that the Roux-en-Y is equal to or greater than the MGB. And again, suture omental patch in this study was reported by a surgeon who received a video from Dr. Billy, a great surgeon. He also did a vagotomy at this time, and my advice would be never to do that, and we can have that discussion later. On the other hand, marginal ulcers are more common in Roux-en-Y, and we think the reason is sometimes there's ischemia, and this is a good example of a non-ischemic, well-vascularized gastro-jejunostomy in an MGB. So again, first rule of Fight Club is to know your enemy, and if you don't know what caused it, you may not know how to fix it. And so etiology, everybody says acid, but as I've said, just a reminder, PPIs are very effective. In other words, like in a Roux-en-Y, there's a subtotal gastrectomy, so there's a lot less parietal cells acid to be blocked. And then even in a normal human, the pH drops from 2 to 6 in short order after a single dose of a PPI. So the total acid exposure, a 10,000-fold change, because remember, pH is a logarithmic measurement. In addition, just a reminder to you young people, we used to operate on something called Zollinger-Ellison syndrome. We don't operate on that anymore, except for extremely rarely, if at all, because we have PPIs. In other words, we can completely block the hypersecretion of acid. So let me just say that again. We can completely block the hypersecretion of acid. We can completely block the hypersecretion of acid. So I think you should stop telling me that acid is the cause of marginal ulcers. And I say, if you don't know what you're doing, you might not know what you're doing. And so again, we're not the first people to say this. In other words, here's a study from back in 2012. The factors for marginal ulcer is, quote, the etiology remains obscure, and they said the incidence might be from 1 to 16%. And I think that's probably correct. In the study from New York, they did not include patients who had secondary treatment outside of New York. So probably the number is higher than 11%. Now, the factors this group mentions, I think, are more accurate than this, it's acid. And again, you don't do a truncal vagotomy. It's not acid that's the problem. The factors that do cause it are, I think, mentioned here. They are local ischemia, anastomotic tension. They mention acid and tobacco and nonsteroidals, but chronic irritation caused by foreign bodies. These things, I think, are not mentioned enough, and I mention them to you today to take it into consideration. And here's another study. Again, the etiology of these lesions is unclear. Size of the pouch. So we used to say, if you're a Roux-en-Y surgeon, they said, we're having these marginal ulcers because we left too much gastric pouch. You young people don't know this, but old gray hairs used to say this. And they say, you have to go back and resect the pouch and make it small. Well, that's just ridiculous. It's obviously wrong. So size of the pouch, foreign body at the anastomosis, I think is a lot more reasonable, but stop with the acid. Let's look at acid after all. And here's a nice study by Dr. Musella looking at sleeves, for example. They have a lot more acid flushing back up into the lower esophagus. And the acid production up into the esophagus as a measure of acid overall gets better after MGB. And so this is in skilled hands, not in other hands necessarily. Using their technique, there's a significant decrease in acid in the lower esophagus. The other example to say that it's more than just acid is, this is a study that Dr. Phoebe referenced on a recent presentation. And a note to Dr. Phoebe, thank you for this commentary. He said that in his USA practice, he was aggressive in looking for, diagnosing, and treating H. pylori, and had a significant experience with peptic ulcer disease after his bariatric surgery cases. When he came to India, work with Dr. Bhandari, they did no diagnosis or treatment of H. pylori, and they found minimal evidence of marginal ulcers. In other words, low to no marginal ulcers in Dr. Bhandari's series. Yet the prevalence of H. pylori in India is quite high. So again, if this is acid and H. pylori as the primary problem for marginal ulcers, well, why are the ulcers always at the margin? And then why are they so common in the United States, where we do treat aggressively, and not so common in India? And I would add to that, that in my experience with Dr. Kular, he similarly did not diagnose or treat H. pylori, and his marginal ulcer rate, I hope I can speak for him as well, less than 1 or 2%. And again, the hypothesis is that it's not just acid. So that means that maybe we can make a difference prior to having a perforation some night. Here's a survey I just did of 12 surgeons, most of whom had experience with over 500 cases. And we talked a little bit about the MGB paradox. And our hypothesis was that marginal ulcers, like other postoperative complications, might be related to surgical technique and postoperative management. So this is from a short talk I did a few weeks ago. And basically the MGB paradox is that some surgeons report excellent results. So myself and many others have seen very low rates of perforated marginal ulcers. On the other hand, some surgeons report very bad results with the MGB. And two examples are the Y-omega trial, which is a nightmare French study, and now they're trying to fix it by shortening the BP limb. And the 2021 study by Australia, they said 10% of all MGBs had to be reoperated shortly after the MGB because of reflux. Well, they're probably really good surgeons, but these are two wildly different results. And so you have to wonder, is it just poor reporting on our part who had good results, or bias, or whatever? The hypothesis is that maybe there's a difference in the actual surgical technique. So if you look at surgeons who use the MGB original technique or the Carbajo-Bagua technique, and the occasional worldwide reports of poor weight loss, excess weight loss, bile reflux, marginal ulcer leaks, and deaths, maybe the difference is related to surgical technique. And so we'll just talk about that. For example, Dr. Lee in Taiwan reported excellent long-term results with MGB. And on the other hand, the Y-omega trial, they had 19% gastritis, 10% esophagitis, and it was much worse than the RYGB. You know, their results are very different. Higher diarrhea and 20%. In other words, 1 out of 5 had diarrhea after theirs. Steatorrhea. In other words, stop doing it, whatever you're doing. Bad outcomes, maybe bad surgeons or surgical errors. 20% gastritis, 20% diarrhea. What does that tell you? Well, if I had that, I'm not sure I would still be a successful surgeon. Possible explanations between the good MGB and bad MGB. The surgical procedure itself could be flawed. Maybe that this wonderful Y-omega trial discovered the flaw of the MGB. Probably not. Could be the surgical technique. That's my hypothesis, and postoperative management is important. Nobody ever wants me to talk about that, but I'd like to someday. So here's what I like to say: how to think about creating the pouch in the gastro-jejunostomy. Avoid ischemia, obstruction, twist, stricture, and foreign bodies. So this will take a minute or two to look over here, but again, if you look here, that's the lesser curvature of the pouch, whether it's a Roux-en-Y or stomach, and this is where we have our vascularity. There's no more greater curvature and gastroepiploics out here. So that means all of this is potentially ischemic. Now, if we do a gastro-jejunostomy here, sorry. If we do our gastro-jejunostomy over here, we have a lot of opportunity for collateral. If we do our gastro-jejunostomy here, now the staple lines are close to each other. All right, I'm just gonna have to talk about it. So what you want is do a staple line so that you don't put the two right next to each other and create a mass of ischemic and dead tissue. That's my opinion. Here's an example of a twisted pouch. Again, if you twist the pouch and cause a partial obstruction at the gastro-jejunostomy, I think that delays exit of acid from the stomach, and so that can worsen it, in my opinion. Here's an extreme version, 180-degree twist. And again, here's some expert data we looked at, and basically reflux after the different operations, band sleeve, Roux-en-Y is higher in this expert panel compared to the MGB. And if acid reflux is higher in the Roux-en-Y, then why would the MGB have more marginal ulcers? Well, maybe because it depends on the surgeon. Here's another example of the rate of marginal ulcers, and you can see that less than 1% in half and 1 to 5% in the other half. Perforated marginal ulcers less than 1% in 83%. there were 2 surgeons who said that between 1% and 2%, and they were the less experienced surgeons reporting. The conservative management was never or rarely by the more advanced surgeons by the over 80%, and sometimes or usually was only 2 out of the group. So a small number. And then management of the perforated marginal ulcer Graham patch was usually or always in 2/3, rarely and sometimes was just one relatively inexperienced surgeon compared to the rest of the group. Convert to Roux-en-Y, rarely, sometimes or never. And one surgeon said always, and again, that was a relatively low volume surgeon. And tube drainage, never 50%, rarely 33%, sometimes, and there was only one again who said usually. So that's kind of my advice. And now we'll summarize and I'll finish up here. Thank you for listening. This is what we said in the beginning, that MGB management of perforated peptic ulcer. So immediate resuscitation, negative exploration, then you're out. Positive exploration for perforation, you have 2 kinds of findings. Basically 90% is going to be a single anterolateral perforation at the gastro-J, and type 2 is more rare. But type 1 is a free lateral perforation, and you do a suture repair, the Gastro-Jejunostomy, Graham patch, aspirate the fluid contents and get out with 2 JP drains. Type 2 is a more massive destruction of the tissue with abscess formation, and so that needs debridement. Divide the gastro-J close to the repair and close the repair, or resect the small bowel, repair the small bowel, and let it go back into the lower abdomen. Then do a gastrogastrostomy using the pouch, remnant stomach to recreate the stomach, drain and get out, plus or minus a feeding tube. And T2 vagotomy, convert to Roux-en-Y, in my opinion, never. For perforated marginal ulcers, prevention first. If you rarely see it, maybe that's a judgment on your surgical technique. I would say so. If you're seeing it more often, maybe it's time to seek advice from counsel from some of your other more senior MGB colleagues. Again, the treatment of perforated marginal ulcer, explore and suture patch in most, rarely divide the GJ, and never, in my opinion, Roux-en-Y or T-tube drainage. Okay, that's it. And thank you all very much. And it's my appreciation for being here today, and look forward to some good questions. Thanks very much.